This conference will now be recorded.
So greetings, everyone. Welcome to another call. And as Rick always does, we'll start off with discovering who would like some airtime tonight. Give us an update. Jake, I know you were just we were just talking about your case. Is there anything else you need to tell us? Or
No, not at the moment. Well, yeah, I do have a question to ask
okay.
about Zytiga.
All right. And look, there's an unfamiliar name, at least to me here, Dean Battaglini.
Yeah, he's the first time he joined us. He's been watching our recordings, but he decided to join us in person.
Is that the store?
It would be me.
Welcome, Dean.
Where's Pepe?
Oh, sorry, guys.
That's okay. Welcome, Dean. Was Len's distracted, I'll fill in. We will give you some priority tonight. So if you're comfortable, once Len's finished his roster, we'll ask you to tell us a little bit about yourself, your situation, and how we can help you. So you have one new person, Len, and it's back to you.
Okay. Yeah, sorry about that. We were babysitting my daughter's dog, and he was underneath the bed here, and she just came in, and the dog had to get out. All right. So we will next move to Dennis. Hello, Dennis.
Hello, Len. I don't have any updates, but I will next week because I got my 90-day Lupron injection coming up tomorrow. Blood work, doctor's oncologist visit down here in Tucson.
Okay, great. Look forward to hearing from you next week.
All right.
Okay, Jeff Dreyer.
Hi. Yeah.
Hi.
I have something,
Okay.
short to ask about. Yeah.
Very good, Jeff. We'll get back to you. And John Appler, good evening, or for you, afternoon.
Yeah, hi, Len. I'm okay. I'm just driving, so I'll just be listening in. Thanks for asking.
Okay. And I see Ken. I presume that's Ken Anderson.
Yep, I'll just listen in.
Okay, Ken. Larry Fish. Hello, Larry.
Mike, test, Mike. If I can, yes, I have some things to discuss.
Of course you can. Thank you, Larry. And next is Les Shelderup.
Nothing for me today, thanks.
Okay. Thank you, sir. Paul Frieda.
Yeah, I got a couple of things going on I could talk about.
Okay, great, Paul. Now, let's see. Is there anyone whose name I overlooked?
You can ask the phone callers if they'd like to speak.
Okay, we don't know who they are, right?
No, we don't know who they are.
Okay, anyone on the phone who would like to speak, please let me know now. Okay, we don't hear anything, so we're going to assume you don't want to identify or speak, and that's fine. So we can.
What about you, Len? Do you have anything?
Do I have anything new since last week? Possibly, yeah, maybe I'll put myself down here. I'm not sure what I left out or what's happened since then, but we can go over that.
Well, I don't know who's running this call, but somebody's got to keep you straight.
Okay. All right. So why don't we start with our newbie, Dean? Welcome, and could you please give us a little background on things like your Gleason score, when you were diagnosed, any therapy as of yet, and where you live might help too.
Okay. First of all, I live in Victor, New York, just outside of Rochester. And I am being treated at the Sands Cancer Center. I was diagnosed, I have a little brain fog, so I hope you can bear with me.
Sure, we all do.
Yep, we all do. Yep.
About a year ago, and my surgeon and my radiation oncologist thought it was quite necessary to do a radical prostatectomy,
Okay.
which I done shortly after that. A few months later, I believe my PSA prior to the surgery was 10.4, something like that. And following the surgery, the PSA was quite low, but each month I saw incremental increases. At that time, my radiation oncologist determined I should get 38 radiation treatments, and also to begin Lupron. And the radiation treatments are complete. I've had the 2 Lupron injections, and that's about where I am right now. I'm going back in October to see where things are. I've been pretty healthy my whole life, so this has been like getting hit by a truck, mentally, physically, and I really enjoy listening to you guys and getting a little support. Sometimes it's pretty lonely in your mind, in your little world.
Yeah.
That's about where I am.
Okay, Dean, did you tell us how old you are?
I'm 70.
Okay. And what level did your PSA rise to before they started the radiotherapy and Lupron?
I don't know the number. It was very low, but it was doubling. So whether it was 0.02, then it was like 0.04, then it was 0.08.
Okay. It sounds like you got to the salvage, we call it salvage radiation therapy, and they say the sooner you do it, the better, and so you did it very soon, so that's in your favor. And when did you say that was completed, radiation?
About a month ago.
And you said 38 sessions. What was it, IMRT or?
Yes, IMRT.
And just to, do you know if it was just to the prostate bed or was it to the whole pelvis?
I'm really not sure. Yeah, I don't. Okay. I don't know. I almost, you've used the terms interchangeably. I don't know if that's correct or not.
Okay.
Have you had a PSA test since you had your radiation or since you started the Lupron?
No.
No? Okay.
All right. Rick, what do you think with the 38 sessions as salvage? It sounds like they probably did the whole pelvic region. What do you think?
Yeah, I think it sounds like it, but I think that you don't know. And I think, Dean, it's important that you ask that question. You need to know yourself for now and for future. It's not, I probably wouldn't call it salvage. I would call it adjuvant because it's so close to the time when you had your radical prostatectomy that it's really more like adjuvant radiation. What was the time gap between when you had your surgery and when you started your radiation? How many months, roughly?
4 or 5 months, maybe.
Yeah. I mean, it's really more like getting adjuvant radiation, which is a good thing because, as Len said, they followed up really quickly. It's just semantics. There's no real difference in what they do, but we call it adjuvant when it's really close to the time when you had your surgery rather than waiting a longer period of time. But yes, Len, I would say it's likely, but we just don't know. Who's your main doctor right now?
Got to ask me the tough questions.
You didn't know there was going to be homework, did you?
I am totally unprepared for this.
That's okay.
Dr. Brasaccio is my radiation oncologist. He's been pretty much the driving force from the beginning.
Who you would consider to be your number one doctor right now?
Yes, Dr. Brasaccio.
What type of doctor is he, though, or she?
He's a radiation oncologist.
Right. So, Len, do you want to take over at this point, since you know where I'm going?
Well, yeah, I think Rick's next question would have been, do you have a medical oncologist on your team right now?
A medical...
Well, let me put it this way. If all you've seen is a urologist who did the prostatectomy and a radiation oncologist who did the radiation, those are the only two docs involved in your case so far. You probably don't have a medical oncologist. But at this stage, after a failed radical prostatectomy and post radiation, and you're on Lupron, you definitely should have a medical oncologist on your team because he should guide your treatment going forward.
I do have another doctor. Like I said, I got a little bit of the fog that what is his title? He's the one who's been giving me the Lupron injections, and the oncologist and he work quite closely together. But you keep asking me the tough questions.
Well, we're asking you for a very good reason. I just want to digress very quickly. I mentioned earlier on before we started the recording that Patient Power asked me to do a recording today. And one of the questions they asked me was, what is the most valuable piece of advice you think you can give to men who have high risk recurrent or advanced prostate cancer. And I said that it is to make sure that a genitourinary medical oncologist is your quarterback, namely a doctor who specializes in prostate cancer, not a general medical oncologist, but one who considers that they have a specialty in prostate cancer. And there are a number of reasons for that, Dean. Probably the biggest is that, first of all, the treatment for prostate cancer is quite different to most other cancers, except possibly breast cancer. The second is that the speed at which the protocols for prostate cancer are changing is so rapid that unless you have an interest and specialize, you're not going to be able to keep up. And so with you in Rochester, probably the closest place where you're likely to find that type of doctor, if there isn't one at Sands Cancer Center, and we don't know, is probably at Roswell Park in Buffalo, which is a couple of hours drive for you.
Right.
But I think we'll ask some of the guys on the call momentarily to chip in and to try and explain to you from their experience why adding a specialized prostate cancer doc is really important. But we know from experience that the absence of a specialty GU med-onc can often mean that you don't get the best possible treatment.
Mm-hmm.
Now, that isn't to say you will lose the other doctors on your team. You may lose your urologist because he really doesn't have a role any longer. You will not necessarily lose your radiation oncologist, although you might not see him that often. And again, also, we don't know the situation with your insurance and what your insurance will and won't cover. But somehow or other, we need to get that specialty guy onto your team. Len?
Yeah, I agree completely with Rick. Very important, Dean, for you to have a GU medical oncologist. As Rick stated, there are so many changes in that research is uncovering in how to manage prostate cancer at your stage, which would be, at this point, I believe, considered advanced. Although it may depend on, yeah, I should ask you, when you were first diagnosed, did they tell you if the cancer was contained within the prostate or had it spread beyond the prostate?
It seemed to have spread. What would it be? Just outside the prostate? The
seminal vesicles?
Yes, seminal vesicles.
Okay. Any lymph nodes involved?
No.
Good.
Okay. And what was the Gleason score?
9.
Was that 4 plus 5 or 5 plus 4?
5 plus 4.
Okay.
Yeah, you're definitely high risk prostate cancer. So you're in the right group here. All of
Dean,
us, almost all of us.
Dean, I have a question for you. This is Dennis. Did you go through any initial bone scans?
Yes, and the bone scan was clear.
Good.
Okay. So, guys, would somebody or more than somebody like to? By the way, I do want to acknowledge Tebow. I know Tebow. We know you're on the call, and as soon as we get done with Dean, who's a new guy, we'll come to you. We definitely want to talk to you. Can you stick around for a few more minutes?
Yeah, I'm here.
Thank you. Okay. I mean, somebody maybe can give their own thoughts on to Dean on the importance of adding a GU med-onc. Somebody like to speak up on that?
I certainly can, if nobody else.
Excellent.
Sure. I had a similar experience to yours, although I didn't have a radical. But I started with a doctor, high PSA. I went to an oncologist who sent me for tests and scans. I had a prostate, mental fog too, and a prostate biopsy and a bone biopsy. And they determined that it was a Gleason 8, and he started me on Casodex and Lupron, which was reasonable, and sent me to a radiation oncologist who was local. But I thought I better go see a specialist, a med-onc specialist, and I ended up traveling to Boston from New York City. But I saw someone as a consultant, and they recommended somebody at Sloan Kettering, and I went to see a specialist at Sloan Kettering, but I didn't change doctors. I kept my original oncologist, and I used the doctor at Sloan Kettering at least to follow my case and help advise me as a consultant. She agreed to that, which was very nice. We got to a point where I ended up denying the radiation that they offered, denying the Xgeva that they offered, following a different path. I was interested in my original doctor because NYU does do Prevenge, but doctor said, you don't know what you're talking about. You're not eligible. You have to be advanced, blah, blah. I was already stage 4. And so I left that doctor and went to my primary quarterback, became medical urologist, oncologist, specialist at Sloan Kettering. And I saw the light, completely different world. Completely comfortable understanding everything we're talking about and doing, who knows, who's involved in research, who's up on things, who discusses things in detail. It made a complete difference. I don't know, this was 5 years ago. I don't know how well I'm doing. I mean, how long I'll be doing well, but I know that I'm in hands that I really can trust. The experience was quite different. So I think it's extremely important to start with a consultation with a GU med-onc, medical oncologist, and then think about switching to have that person take over the case and work with your people until you decide you want to stay with your people or not. I don't know. It was my experience, and it was kind of life-changing for me.
Larry, don't you have a doc in upstate somewhere that you like who's a good GU med-onc?
Dr. Audio at Sloan had worked with but he was in Binghamton, so there's no special advantage. She had someone who she'd worked with before who couldn't, in case I was going to be moving upstate, and I saw him and I liked him, but I saw him 3-4 years ago, and I haven't gone back yet because I'm still living in New York City.
Is Binghamton any closer to Rochester than Buffalo?
Kind of similar. Binghamton's, an hour or something from Syracuse. Syracuse is a couple hours from Rochester. I think you can go sideways. But anyway, I still think Roswell Park may be better to see the best guy you can.
Right.
That's my suggestion. At least to consult and follow to start. I think it's important.
Thank you.
Dean, you're on the computer, right? You're using GoToMeeting software?
I'm on my phone. Yeah.
The Paul Frieda just posted the name of a GU medical oncologist in Rochester named Dr. Fung, F-U-N-G. Can you see that?
No, I cannot.
In the chat box? No?
Let me check that here. Oh. I can't.
There should be something that says chat on your panel there, and if you open it, there'll be a bunch of messages in there.
Right. Okay. I've gotten that far. I don't see the.
You may have to scroll up or scroll down to find it.
Yep, I did find it now. Thank you.
Fantastic. Fantastic. So, yeah, I mean, we don't know the doctor, but, you know, we don't have any experience with him. There's one doctor we know very well at Rochester who is a GU med-onc, but I'm not, I have to be candid, I'm not super impressed with him in terms of how aggressive he is, but I think he's good. I think he would certainly serve your purposes well, and we certainly have confidence in him. His name is Chatta, C-H-A-T-T-A.
C-H-A-T-T-A?
Yeah, he's an older guy, and he's you know one of the principal GU med-oncs at Rochester at Roswell Park. I don't know the other medical oncologists at Roswell Park. I think that's the only one that we have experience with.
Mm-hmm. Well, this Dr. Fung is with the University of Rochester, and my radiation oncologist is affiliated with the University of Rochester also.
Okay.
So maybe that might be a good connection.
Excellent. Yeah. And you'll tell us whether you like him, you don't like him. You know, that's how we learn as well.
Oh yeah, I'm more than happy to share anything.
That'd be great. That'd be great.
Indeed. I think we didn't ask you, was there a specific question or questions that you had for the group when you first came on?
No, not really. I think it has helped by me sharing some of my info and getting, you know, your input to it, give me some good direction, because it can be confusing sometimes. I've had one thing lead to another while being treated for the prostate. My oncologist did a chest CT and a lower abdomen, and doing the chest CT found I had a growth on my thyroid, which put me in the hospital again for thyroid surgery. I mean, I've been going off in so many different directions, and
was it cancerous, the growth, or not?
No, it was not. Thank goodness.
Okay, terrific.
Well,
Yes.
I missed for a couple of minutes, but do you have anybody who you're close with who is helping you, or you discuss with, a partner or a friend, somebody you can rely on to maybe drive you if you need to go for a procedure or something, or you're handling this mostly on your own?
My wife has been very helpful when I can't do things on my own. She's taken me to appointments and surgeries and all that.
Yeah, that's really great, because that can be important help.
Yeah, it's I just find maybe the most difficult part for me is dealing with the emotional and mental part of this, which doesn't seem that most people can relate to, unless it's like you guys who've been there. And there's a lot of time that I feel quite alone in this, and listening to this doctor, should you go here, and just gets confusing.
Dean, this is Jake.
Jake.
I have your email address. It's whatever it says. I can't read it with my bad eyes, but I'll send you a couple of links to emotional support groups. One run by the Reluctant Brotherhood, which is every week, and then there's another one run by Answer Cancer once a month. And I will send you both of those schedules and the call-in instructions if you're interested.
Okay? I appreciate it. Sure,
no problem. And we also have a call for caregivers that your wife might be interested in attending. That's on second and fourth Tuesday, Rick, is that right?
First and third.
First and third Tuesday. That would be the same call-in information that you used today.
Okay.
8 o'clock Eastern time. And your wife might very well, be interested in calling into that one. It might be of help to her. Because being a caregiver is kind of hard too. It's we forget sometimes that they're going through this with us.
Yep, I know that. She's had to assume a lot of the things that I had been taking care of. I believe it's the Lupron that's just beating the hell out of me. I'm exhausted. I don't have energy for a whole lot, so she's had to pick up a lot of duties along the way.
So I just want to chip in with a couple of little things here, Dean. First of all, our Speaking Freely group is the third Thursday of every month. And you will dial into it exactly the same way. And if you go to our website, you'll find information. The group's called Speaking Freely. And it's specifically to talk about all these issues which are not related to treatment that you're mentioning. And it's a men-only group, as is the other group that Jake will give you information on. Our group is a little bit gentler than the Reluctant Brotherhood group, but we don't meet as often, at least not right now, we don't. So that's one thing. The other thing I wanted to say to you, and I've put you on our mailing list, so you'll get regular notifications of the groups, of the Speaking Freely group. You'll get a notice, and before each of these meetings, you'll get a notice going forward. But the thing I did want to say to you is that we can help you a lot in terms of how to mitigate some of these issues around hormone therapy and the Lupron, the LHRH drugs. I'm not sure we have time tonight to get into it, but we would encourage you to keep calling back. And maybe when you call back next week, you'll say, what can I do for this fatigue? And we'll get into that in detail. Every guy on this call is familiar with that fatigue. And we found ways to mitigate it, and we'll share those with you.
That would be great. I'd really appreciate that. And I know you guys have taken the whole session so far, just speaking with me.
So that's as Jake says, it is our pleasure, and that's what we do when we get a new person. But we do have to move on, and in particular, somebody that we need to visit with who cannot always stay on the call the whole time. But come back to us, and we have your number now. Stay on the call too now, because you'll hear other things. Come back to us, and we'll work with you next session on on what you can do. And also I'll send you, and I think it's linked under prostate cancer resources, but I'll send you the UCSF pamphlet on hormone therapy, because there may be a lot of information in there that your doctors didn't cover for you.
Okay, that's all great. I appreciate all your help.
Okay. Len, go ahead.
Okay. One thing we can tell you before you leave, Dean, is just start exercising. You don't need to wait for our next meeting. We guarantee we're going to tell you that. So, all right. Thanks for coming on, Dean, and we hope to see you again.
Oh,
And
you will. Thank you too, Len.
okay.
Please
And
stay on and listen
as
please
Rick
stay on and listen to the rest of the call.
I'll be here.
We're not dismissing you.
mentioned, Thibaut has joined the call, and we definitely would like to give you as much time as you need, Thibaut. So if you're ready, you have the floor.
All right. I completed 5 of the 6 lutetium treatments. But right after my 5th treatment, I started feeling kind of numb and tingly and clumsy just on my right side, right arm and right leg. Had a little trouble walking, and I kept dropping things. And I was hoping it would progress slowly enough that I could get my 6th treatment of the lutetium, but it started happening every other day and then every day, and decided I had to go to the hospital. So I saw my oncologist, and he sent me to the emergency room, and I got admitted. And, they thought it's probably not cord compression, it's something in the brain, because if it were in the spine, it would be both sides and not just one. And they were right. They did a CT scan of my brain and found that there's cancer in the dura lining, and it was sufficient to shift the position of my brain like 3 millimeters. They recommend whole brain radiation. And I got started yesterday. I've had 2 treatments so far. I asked them whether it was going to cause problems with my shingles and post-herpetic neuralgia. And he said probably not, and he's wrong. My skin's starting to hurt already.
Oh no.
It's only been 2 treatments. So I'm using Banafin lotion and continuing the gabapentin. I'm worried that the pain's going to get worse. And I've got an appointment to see Dr. Denmead, my oncologist, just before I finish my series of 10 radiation treatments, and discuss what's next, because anytime I go without treatment, my PSA tends to double every 2 months. So I don't know what I'm going to do after this radiation.
Thibaut, you may be aware that Professor Bill is in a similar state. But one big difference, and something that I have read too, is, and I would, even though I know you've had 2 sessions, I think you've got to get hold of the radonc and find out why they're giving you whole brain radiation instead of using CyberKnife. You know, I don't know that unless they've seen. I mean, you say they saw a 3 millimeter lesion in the
No,
door.
the whole brain was shifted 3 millimeters to the side because there's so much cancer all through the lining of both sides of my brain.
Oh, okay. So it is extensive. It's more than a single lesion.
Oh yeah.
Okay, that's why. Okay, then you've answered my question. I thought it was more specific, and that's why they're doing whole brain. Okay.
Yeah. They say I'll probably, lose some short-term memory eventually. It's kind of a gradual process over a year. The more immediate symptom is fatigue for the first couple months, and apparently in pain as well.
Okay. Okay.
How many sessions of the whole brain radiation do they plan on doing, Thibault?
10.
10, and you've had 2 or 3?
2.
2.
Yeah.
So aside from the aggravation of the shingles, no other side effects, any benefits so far?
Not yet. I've been having, they've been giving, when I entered the hospital, they started giving me steroids, which reduced the swelling in my brain and reduced, it eliminated the numbness and the tingling, and but I have had some just aching in my arms and legs, and it wasn't that bad when I was in the hospital, but the last day it's gotten worse. So I've increased my oxycodone dosage. Hopefully the radiation will help with that. I'm just guessing that the aching is from the brain problem because it's kind of new. I haven't had that aching before.
Well, I mean, one thing I can share with you is that Bill had 2 sessions of CyberKnife about 3 weeks ago, I would guess now. I think the last session was 3 weeks, so probably 4 weeks ago, 3 weeks ago. As of this morning, and we'll give you a report on Bill later, but as of this morning, he feels terrific. Now, and he's not doing any other treatment. Now, whether that was a result of the radiation or not, and at the time that he was going through the radiation, he didn't feel good and he was not in good shape. But he's feeling way better. I mean, I called him up today. I Skyped him today. I said, "How are you, Bill?" "I'm great." I said, "What are you doing?" He said, "I just cleaned the bottom of the house." I said, "Get out of here." So, I mean, he couldn't even walk when I saw him. I mean, he was having trouble putting one foot in front of the other. I mean, he's still using the frame, but only because he feels more secure. And they just brought a cane over for him today. So he's doing great. I mean, I don't want to say great, but he's doing better than he was 3 weeks ago. So I want to drop that in as something positive, especially since he was not doing great at the time that he first had the sessions.
That's great.
Tebow, I had a question. How much oxycodone are you taking?
I was taking 15 milligrams like once a day, but recently I've been taking it 2 or 3 times a day, and my last dose I took 30.
They just did a piece last night on 60 Minutes on, there are literally tens of thousands of people that are getting addicted to it and dying. And so you got to be really, really careful with that. I understand you're in pain and, you need something, but you better make sure you have a good medical supervision, because that's really dangerous stuff. And the temptation to keep increasing it is very strong. And so I hope you're aware of how dangerous that drug is.
Yeah, my usage goes up and down. I always, move it down whenever I can. And I've been taking it for a long time, so I only make relatively slow changes.
Okay, I hope you're in control.
Len?
Yeah.
Tebow, this is Jake. And I know Paul means well about the oxy, but my oncologist told me that cancer patients generally do not get addicted. So it's we're not using it for recreational purposes. We have a need for it, and addiction is apparently very low among actual cancer patients. So I don't know if that'll make you feel any better.
Well, technically, I am addicted because I couldn't, go cold turkey. I would have to go down gradually.
Well, we need it, yeah. I mean, there's a point where we all need it, obviously. But just my 2 cents.
I think the overriding concern is to keep your pain under control. I wouldn't worry one way or another about the addiction.
Right.
Yeah.
Well, we really thank you for coming on and sharing your experience, Tebow. It's good to hear from you. Does anyone else have questions for Tebow? Or Tebow, is there anything else you want to share with us?
No.
Anyone have questions for Tebow?
The only thing I would like to say to Tebow is, Tebow, just don't hesitate to call on Len or myself or Jake or any of us in between calls if there's anything that we can do for you.
Okay, thanks.
Well, thank you. Thank you so much for coming on.
Guys, anybody else that wanted to say anything to Tebow?
Yeah, it's Ken Anderson. I just wanted to say hang in there.
Thanks.
Thanks, Ken. Thank you, thank you. We all want you to hang in, Tebow. You are pretty amazing, and we're really honored to be able to support you and to hear your voice, and we're always here for you.
Good luck, brother. Stay in touch.
All right.
All right. Jeff, you mentioned you wanted some airtime tonight. You're up.
Hi. Yeah.
Hello.
Hello. Can you hear me?
Yes.
Hello. Yeah. Good. Yeah, I just wanted to show you. Let me see. Turn on my camera. Okay. Wonder if you can see. Can you see what I'm
Yeah.
holding up here?
PSA chart?
No, this is testosterone.
Oh, okay. Yeah.
So I went off of Lupron at the end of December last year, and so this is my last. So you can see that it rebounded almost back to normal as of about 3 weeks ago. That's when it was last tested. So that's nice. The PSA is up a little bit though. It was undetectable for a year, and now it's the last measurement was 0.135. And I was told by the nurse practitioner that that's normal, expected, since I still have a prostate, and that they'll just be watching it. And then if it gets up to 2, they will consider that as a biochemical failure, I guess. But I just wonder what you guys think about that.
Could you give us a quick summary of your background, treatment, and diagnosis, Jeff?
Oh yeah, well, so I had let's see, January 2017, the biopsy showed that I had a Gleason 4+5 cancer throughout everywhere in the prostate and some extracapsular extension. So I had IMRT, let's see, 5 weeks of that, 5 times 5, I guess, treatments, and 2 years of Lupron injections and enzalutamide also for 2 years. It was a clinical trial. And I finished the enzalutamide at the beginning of May of this year. So, yeah, that's a
Okay.
And
thumbnail sketch.
what is that T level, Jeff? I know it was on the chart, but I couldn't read the chart.
Oh, okay. Testosterone level, yes. So it started back in 2014. I had it measured because I wasn't feeling too good. It came out at around 600. Let's see, nanograms per deciliter. And then it went down to 15 or something, and then the latest measurement is 533.
Okay.
Yeah.
Well, I don't want to say we told you so, but we said be patient, it'll come back, because I know you were very concerned, and we said give it some time, it'll come back. And so the first thing is we're delighted it's back. And how do you feel in yourself?
I'm feeling a lot better. I can feel my power, my mojo coming back. So I'm very glad. I'm still having like some little bit of hot flashes and night sweats, and I was told that's also normal. My body is still kind of adjusting to things. But so I'm very pleased with this result. I guess my question though is if the PSA is of any concern, or just does that seem okay to everyone?
Well, you had IMRT and HDR, correct?
Yes, HDR, right.
I would, if it were me, I think I might be a little concerned about that 0.135 level, but let me at the same time say to you, as you recall, and I think I've sent you that chart and that diagram, that when I came off of my treatment, which was low dose brachy, not high dose brachy, and 28 months of Lupron, that my PSA climbed for a year.
Mm-hmm.
And almost 1.0, like 0.98, I think.
Okay.
And we always tell folks, I know I've discussed this with John Appler and others who do this type of treatment. Don't be too concerned if your PSA rises for quite a while. And we can explain it. I mean, look at that chart I sent you a few months ago.
Yeah, I remember that. Yeah.
Remember that chart? And remember how your PSA will tend to climb until it coincides or hits the slope of where you would have been if you'd done radiation without any Lupron.
Yes.
And when it hits that point, it starts to go down. So on one level, I agree that there's some concern because your PSA is not immediately zero. On the other side, experience tells us that your PSA will rise for a time, then hit a point and then come down. Where exactly, how much it'll rise and where exactly that will be, we don't know. And, I was relatively sanguine about it. And Matt Roach would say to me, don't worry, it's going to come down, it's going to come down. And then I'd get a test and it would be higher. And then I'd get a test another month and it would be higher still. And then I'd get a test the next month, 3 months later, and it was higher. And I'd write to Mac and say, Mac, it ain't going down. Yeah, it will come down. Sure enough, he was right. It came down.
Okay.
Go ahead.
So what is it now? Is yours back down to undetectable or?
Yeah, it's been undetectable for probably 5 years now.
Because I was told the nurse practitioner, who was a very nice lady, Alice Choi, and she said that that I should expect to have some. I mean, it would not be surprising if I'm making some PSA since my prostate is still, it's not completely obliterated, I suppose. So
I don't agree with that. I think she gave you bum information and she's probably not well enough informed.
Okay.
There's a real problem in that there's been very little published on how on the pattern of PSA once you stop this treatment protocol that you and I both had. There's a fair amount being published on the testosterone, but almost nothing. And I just wish that somebody would write a paper. I offered to work with Albert Chang on doing a paper, but then he left and went to UCLA. But I just think somebody needs to do that paper because there's no reference. I mean, Stephen Frank of MD Anderson drew this little graph for me on the back of a napkin when I sat next to him at a conference.
Okay, yeah.
And when I've talked to other to other radoncs about this, some will say, "Oh yeah, well we know that. Yeah. Well, this isn't any." And I say, "Well, why doesn't somebody publish it for goodness sake? Why don't you tell the patient to expect that their PSA is going to rise? Set their expectations, because if you don't, and it keeps to rise, and it rises month after month after month, unless you're fairly cool with it, you're going to be going out of your mind. I mean, if you're a nervous Nelly, which might possibly be the category we hire.
No, I'm not. I'm not horribly worried, but I just want all of your guys' advice and wisdom here.
But we know from past history that you do get concerned quite easily and with reason. And so, that's why we want to put your mind at rest.
Yeah. Okay. That's interesting. I might even send this Stephen Frank an email at some point to ask him about this. If that.
If you do, remind him that he sat next to me at the Millikan conference in DC in 2013, I think it was.
Okay.
And that he said that he would write this up, and I would volunteer to write it up with him or do anything I can, but I would love to see this published.
So that's fairly long ago by today's pace of things. 2013. Huh.
Yeah.
Yeah. Wow. All right. So I'll see how it comes out. Yeah. I'll ask some questions. I'll follow up with some questions with Dr. Koshkin as well.
Okay. Anybody
Okay.
else have any input on this or similar experience? Yes, not.
I'm sorry, Jeff. My connection got dropped, so I missed a lot of what you said.
Oh.
I'll just assume that the guys did a good job in answering your concerns.
Yeah. Yeah.
Okay.
Okay. Yeah. You can. Okay. Yeah. The gist of it was that my PSA rose a little bit on my last test after my testosterone has come back, and I just wondered if that was a concern or normal. I was assured that it was expected, but Rick says that it's a transient increase, and I should see it go back down again eventually. So,
yeah, you had radiation, right?
Yeah, IMRT and HDR brachy.
Yeah, it could be radiation bump.
2 years of Lupron and enzalutamide also.
In any case, I guess I'll just quickly state my experience. I post radiation, my PSA rose over a period of about 6 months from 0.1 to 0.5. I'm Gleason 9 like you, extracapsular extension, 2 lymph nodes involved. And my oncologist at the time said, I have seen guys have their PSA plateau at that 0.5 level. And I said, well, for how long? And he said, well, sometimes indefinitely. So in my case, it plateaued there for over a year before it started rising again. So you might have a nice drug holiday as I did.
Well, but Len, let me say there was a difference in that you knew that you were metastatic, it isn't clear whether Jeff was or was not. He was in the same boat I was in, so it may well be, as I said, you missed it. My PSA went up to almost 1.0 before it came down. And there is an explanation for that, which I've shared with Jeff in the past.
Okay.
So I don't think that you still have the disease. You could be like me, and you could have durable remission, or you could be like Len, where it's put the disease in hold for a while, but you can still hold out for the fact that you have you have a durable remission. You don't know. It's going to be, it could take you a year to find out.
Yeah.
Okay.
I'm sorry, I don't know what happened with you, Len. After that, it began rising again, and then what happened? What did you do then?
Well, after it broke through that threshold of 0.5, 0.6, then it steadily started climbing again. And then I had to wait. I did an Axiom scan in December of 2018, and it didn't really show anything. I had bone scans. They showed nothing. I got into an NIH clinical trial using a PSMA PET scan called PYL. You may have heard of it.
Yeah.
and I just had that done in July, and that revealed some bone lesions. And they did a biopsy on one of those lesions in my right hip, and it was positive. So now I'm back on Lupron, and shortly I'll be adding Zytiga.
Okay.
But I mean, I've been asymptomatic all along. I had very high testosterone recovery, like you, and for 30 months I was completely off therapy.
Yeah. Okay. And that's where it had plateaued at 0.5 for like 30 months, you say?
No, not 30 months. It plateaued at the 0.5 level for maybe, I don't know, 13, 14 months.
Okay.
And then it started rising again.
Yeah. All right.
If that happens to you and you start getting a little anxious, maybe time for a scan.
Yeah. All right.
But we hope that you're in my boat and not in Len's boat. That's what we're talking.
Yeah, for sure.
And there is possibility that you will be. Don't drive yourself crazy if you continue to see this PSA rise for the next few months. Go back, look at that chart that I showed you, that I sent you.
Yeah.
And by the way, I'll be in Marin over the weekend. I'm staying with Dave.
Oh. Okay. Huh. Maybe I could. That'd be nice if I could meet you face to face sometime. Never actually.
Well, I'll be up in Nevada in the studio because I think your brother has sold the house. I'm not certain, but I think so.
Okay.
Okay. But do you have my telephone number?
Yes, I believe so.
Okay. So you'll just call me.
Okay. Great. Thanks.
Anyone have questions for Jeff before we move on? Okay, well, thanks a lot, Jeff.
Thank you all. Yeah. Thanks, Len.
And how about if we go to you, Jake? Brother Jake.
Hang on, here I am.
Okay.
Sorry about that. I was typing an email to Dean. What did I say? I just have a question for anybody who's been on Zytiga. Well, first of all, when I was on Xtandi, the first month or two, I had a lot of palpitations. Like it feels like your heart's flipping over in your chest, and it went away. Now that I've been on Zytiga for about a month and a half, I'm having the same thing again. And I was just wondering if anybody else has ever experienced that or not. And I have had palpitations off and on since I've been in my 20s. And so I generally don't worry about it. But I don't know if the Zytiga is making it worse or not. And I was just wondering if anybody else has experienced anything similar. Feels like your heart's flipping over in your chest, basically.
Hey, Jake, it's Dennis.
Hi, Dennis.
I think I mentioned this before. I did have what I thought was not necessarily palpitations, probably not as severe as what you had, was more like skipping a beat.
Yeah.
I could feel it in my chest, and it would come and then it would go. And there was information about people that had pre-existing heart issues, and Zytiga, I believe, were having some sudden heart attack type issues.
Oh, lovely.
And so I immediately talked to my my med-onc and told him what I was thinking. He didn't think I had a problem. I didn't really have any serious heart things, but earlier I'd had a mitral valve prolapse issue.
Yep.
So he said,
I've been told I have that.
Yeah, and in fact, what I guess in the past that had been over diagnosed and not to be a main issue.
Right.
Oh, but anyhow, they set me up to do the full treadmill deal with the cardiologist and checked everything out, and everything was good. And he said, don't worry about it. And after I got that done, it seemed to almost disappear. I very, very seldom now have it. So I don't know.
Well, that makes a lot of sense to me, Dennis. Thank you for that. Like I said, I've had them off and on, for, since I was in my 20s. I've had stress tests and all that, and they say it's nothing. And again, I had it when I first started taking the Xtandi. It went away for the most part, and then I've been having it the last few days with the Zytiga, and I'm hoping the same thing. I'm hoping that it will go away, and I'm trying to do like you said, just don't worry about it. But I've been told years ago that I had mitral prolapse, even though apparently, like you said, it is overdiagnosed. And nowadays, when I get an EKG, they don't even see it.
Yeah, they saw some stuff in my EKG, and but they said it wasn't anything to worry about.
Right.
So I basically the cardiologist said, unless you're having problems, I don't need to see you again. So
Good. Well, thank you, Dennis.
okay.
That's all I had, Len.
Yeah, I would just add this, Jake, that if you start experiencing extreme fatigue over and above what you would normally expect from being on Xtandi or Zytiga,
Right.
if you're feeling faint, those are maybe triggers that you should see a doctor, maybe even a cardiologist. But if all you're getting is that occasional skip a beat syndrome, which they say is actually an additional beat, probably don't need to worry about it. If you're asymptomatic in every other way.
Well, I don't know about you.
I say that because Marguerite's husband Tony was on Lupron for quite a while, and he was experiencing extreme fatigue, fainting spells, and he went to see a cardiologist, and he had to have a pacemaker put in, which may have saved his life.
Right.
So, just something to keep in mind.
Okay. Thank you. Yeah, I do remember that about Marguerite. Now that you mention it, he did have a pacemaker.
Yeah.
Okay. Well, thank you, Len. I appreciate that
Sure.
too.
Anyone else want to? Anyone else have any suggestion for Jake? Okay, thank you, Jake. How about if we move on to Larry Fish?
Unmuting. Hey,
Okay.
guys.
Hi.
Fahina, quiet. Okay. So I went to see my doctor a couple weeks ago, and my PSA over 2 months rose from 0.19 to 0.33. I've been on Lupron for almost 5 years. The plan right now is to go in September for scans and one more PSA test, and then depending, basically consider Lupron or looking at trials for Lupron plus something. The scans I would be getting probably would just be the usual bone and CT. But if we want to look for something, Sloan still has ability to do Axiom. We talked about the Cornell PSMA scans, like the kind that Len did. Her feeling was the main reason for that might be to think about doing a focused radiation, if they found something, but she herself is not clear yet, not certain if that leads to change the course of progression and or metastasis very much. As most likely there might be a few spots, since I already started with a stage 4 in my bones, and many other spots probably 4.5, 5 years ago. So does that seem like a reasonable plan? Do you think I should push for more intensive scan? And the plan to go to Xtandi or Zytiga. I don't want to revisit this too much, but I've listened to a couple of discussions about the cost, but I'm concerned about how the cost is going to be. You go in the donut hole, out of the donut hole. I'm still working, by the way, but then my Cigna, my health insurer. It's a category 5 drug that I'm supposed to pay 25% of, and the price is between 9 and 11,000 a month. At Sloan, they have the financial services. They said it can be considerably different even if you're working, have an income. But I just wonder if anybody here has an idea how the actual cost ends up. That's my story.
Okay, guys,
Well,
some of you have gotten financial. Let's start at that point and share with Larry, please.
Larry, this is Jake. Yeah, I had financial assistance for Xtandi. You know, my insurance paid all of it except $30, and the company itself paid the other $30.
Wow.
Yeah, so that was really helpful. But I'm on Medicare, but they don't cover medicine, so I had to depend solely on my insurance, my secondary insurance, which is Blue Cross Blue Shield Federal. As far as the Zytiga goes, I'm getting the generic Zytiga, so I couldn't get any financial assistance, obviously, from the company that makes it. But even then, my copay is $50 a month.
That's with your secondary insurance kicking in?
Yes, sir. For what that's worth. Now, if you get the are you on Zytiga now?
We didn't know. We're still waiting to do a scan and one more test before we switch,
Okay.
before we add it.
Well, if you get the generic, you'll probably run into the same issue. There's no financial assistance available. But if you get the name brand from, is it Pfizer, Rick, that makes Zytiga?
No, Janssen.
Janssen. You may very well be able to go online and apply for financial assistance from them. Understandably, they're not too happy about generic Zytiga, so they're not going to help you. And I don't know how much of a cost savings there is between the two, to be honest. But
they're also not happy about the $572 million fine they just got slapped with for the opioid abuse.
That too.
Yeah.
So I don't know. Does that help you, Larry, at all?
Well, I'm not sure. I hope it does not. Certainly doesn't hurt. I don't have. I didn't go. I'm still working. I didn't go on Medicare yet.
Right.
My question is, I mean, I don't know. We've been discussing with a friend who is sick with cancer, breast cancer at work here, but just wondering if you start to also go on Medicare, does Cigna become your secondary, or they don't overlap if you're working? I don't know that they overlap.
Well, again, it depends on the plan, but yeah, generally, like I said, Medicare does not normally cover. Medicare A and B do not cover pills, which is what Zytiga and Xtandi both are. So I've had secondary insurance that I got from my government job that I carried over, mainly because I need to cover my wife, who's not on Medicare yet. But yeah, so generally for a shot or office visit or whatever, Medicare covers part of it. Secondary insurance pays the difference. On the medicine itself is normally, on the secondary insurance for medicine, it's generally 80%. But for some reason, they are paying a whole hell of a lot more than 80% of the cost.
Yeah.
I'm thankful for that.
I'm thinking about the whole Medicare Part D thing. If it's pills, that there's a donut hole. The same thing with Cigna. There's a maximum amount of pocket. I don't know what happens. I think after that, in Medicare, it goes to now, I think 5%. 5% of 10,000 is 500 a month. I don't know if that rule applies yet, but they were talking about you go in the donut hole at 6,000 something, you come out of the donut hole, and then they cover it. But now it's a question about the other 5%, if that's in Medicare or not yet.
Right.
All right, that's just my question.
So let me tell you what I know. And this relates only to Medicare supplementary plans.
Yeah.
And the Medicare supplementary plans are distinct from whatever private insurance you have through your employment. And that you would have to ask them what your maximum out of pocket is, or it should tell you in that plan what your maximum out of pocket is per year, but there would be a limit on it. So you'd have to look at the plan or call the plan administrator and ask them to tell you.
Yeah. I think you're talking about like the AARP Plan F supplement, which is
Right.
the best, or GRF.
What I'm saying is that I can tell you those plan supplements that you just mentioned, but I cannot tell you about your own Cigna plan that you have through your employer.
Right. Well, I could just drop that, switch to Medicare with supplement if there is a maximum out of pocket total.
Right. But the first step is to find out what your maximum out of pocket is on your program at work. My guess is it's going to be lower than the Medicare supplement, but I don't know for sure.
Yeah, I think it's 6,500 or 7,000.
Is the maximum out of pocket?
I think it is.
Okay,
But
well
Yep.
let me just finish, Larry.
Sorry.
So just call your call your plan administrator and just ask them what's the maximum out of pocket I would have to pay for this drug, and name the drug, because also usually the drugs are considered as drugs by mouth, but some of the cancer drugs are considered not, even though you take them as a pill, they're considered to be chemotherapy. So it depends on your plan. Now, for the supplement, I'm pretty certain they are not considered to be chemo. However, the donut hole limits your maximum out of pocket. So you will pay whatever your part is until you reach the donut hole, which might be 1 month's supply or 2 months supply. And then after that, it goes down to a negligible amount. So the donut hole usually runs you about 4,000 to 5,000 out of pocket a year. There's also an option when you sign on for the first time, which you will be doing. You cannot be excluded. Existing conditions are not excluded. And there are some drug plans, even though they're more expensive, that cover everything, but you pay more for them. So instead of the drug plan costing you $40 a month, it might cost you $70 a month, but you have no deductible on it. And you can sign up for that now, even if you were on Zytiga, you could sign up for it. So
Yeah.
that might be an option for you. So really, there's three things to look at: how much you're paying right now, you would pay right now in your current plan, what you would pay under various plans of medical supplements, various plan Ds in sub, because you have the option of more than one plan D. D is the drug coverage one, isn't that right, guys?
Yes, that's true.
Okay. So that's really what you got to. Who on the call has had experience? Dennis, I mean, you've had some experience with this, right?
Yeah, I've got my Part D. I have through Humana, and for the Zytiga, has to come through a specialty pharmacy. You know, their list price is like $11,000 a month for this drug, and through this plan, it cost me right now I'm paying $585 a month for my Zytiga. However, and I think that's past the donut hole. When you pass the donut hole, it goes down, and I'm not aware of any max through this Humana drug plan that I've got for Part D. But I have a separate benefit as a GE retired executive. I get a maximum. They set a maximum for me of 5,000. So anything I pay out of pocket for over 5,000, I get refunded by my ex-employer.
I see.
That's my situation with the Part D.
Okay, I think I have this picture to explore.
Let me hold on, Larry. Dennis, what will your copay go down to once you pass the donut hole?
I think that's what it is now. Hold on a second. I gotta grab my binder. I'll be right back. Keep talking.
Okay.
All right, I have one more additional. Do most people able to work once they go on Zytiga, or do most people end up retiring? I wonder how that goes. It's very variable.
Yeah, I think it depends on the individual and the extent of the effect it has on your cognitive functioning. I
Yeah.
know you guys who quit because they said they just couldn't do their job anymore, and others who apparently do continue. You'll just have to wait and see how it affects you.
Yeah, that's what I
Yeah, I
was
mean,
thinking.
you seem to have tolerated Lupron quite well. As a matter of fact, I'm amazed that you were diagnosed 5 years ago, metastatic, Gleason 8, I think you said,
Yes.
and you've been on nothing but Lupron, no other primary treatment, and your PSA is only now just beginning to rise, show signs that you're castrate resistant. That's pretty incredible to me.
Yeah. Three
Um,
3 years ago, it rose, and we cut the Casodex, and then it dropped again, and now it's starting to rise again.
are you still on Casodex?
No, we stopped that after went up to 0.3, 0.5, 0.6, 0.7. We stopped it.
And then it went down.
Went down.
Yeah. Well,
Well, yeah. Well,
so to answer your other question, which was, did your plan seem reasonable to try and get an advanced scan? Your PSA, I would say, is still a little bit on the low side for any scan to pick up any
exactly.
lesions. So you might want to wait there. But I'm not sure you want to wait, being that you have a history of metastasis. I'm not sure. And now that you're apparently castrate resistant to Lupron, I don't think I would wait uh, to add in, either enzalutamide or Zytiga or
Yeah.
apalutamide. What do you think, Rick?
That's what
I would agree with you, and I understand what Dr. Audio is saying, that in your case, doesn't really matter what the scans say because we know you're metastatic. So it's not like Len trying to figure out the extent of the metastasis, and we also know that you have many Mets. So, if we thought you were only going to show 2 or 3 Mets, that's one thing. On the other hand, we also don't know how your Mets have changed since when were you last scanned?
6 months ago.
Okay, and how many metastatic sites showed up on that?
Everything. Well, they said they're resolved. There's nothing active.
Okay, so
maybe it was a year ago. Yeah.
Okay, so if there was nothing active a year ago, then there might be reason to do a detailed scan again now, or any sort of scan again now. I mean, the Axumin, as Len says, both the Axumin or the gallium or the 18FDCFPYL probably aren't going to show much until your PSA gets closer to, well, it gets over about 0.65. If the regular bone scan just showed something, The question then is it worth spot radiation? And, you know, I understand what Dr. Audio is saying. Somebody like your case, we don't know that it would resolve it. Len, what you're facing that situation right now. What do you, if you had at one point multiple Mets, then they all resolved and went away. Now your PSA is going up and you see a Met. You personally, what would you do? Would you shoot it with spot radiation or not?
If my history was multiple Mets, is that the question?
Yeah, if your history was multiple Mets, but the last scan showed nothing, and this scan showed one Met.
Yeah, the question is, what type of scan was it? Was it a technetium bone scan?
No, Rick's talking about the hypothetical next scan.
Oh, hypothetical next scan.
Yeah.
If it showed nothing.
No, it showed one Met.
If it showed one Met. Okay, it's a difficult question for me because I had an Axumin scan that didn't show any bone Mets, and I had two technetium bone scans that also showed nothing, and then I had the PYL scan that Rick just mentioned, and it showed several. So the question is, should you be treating a single Met when you're not using the state-of-the-art scan because there might be other Mets that you're not seeing, in which case, do you want to risk? Well, in your case, though, you haven't had any radiation, so I guess there's probably less risk for you to have spot radiation because you haven't had any prior radiation to complicate things.
Yeah, it's kind of complicated.
It is. It's a tough decision. I don't know how I guess you have to rely on your doctor's opinion.
Yeah, well, we can work it out together. We'll both discuss it and come to something. There's even an additional thought I had. Sorry to take up 2 more minutes if it is. That what about going back on carboplatin or another chemo for a little bit and see if that knocks the PSA all the way down again? Or is
Yeah, that was my first thought. And so I scanned up and looked at your history and saw and recalled that you had a heck of a time with docetaxel.
Yeah, I did.
So I was going to suggest, but we sort of got sidetracked, that one thing, if it were me, that I might want to discuss is whether my doc thought I should try cabazitaxel, Jeftana, because it does have a lower side effect profile, and it might be effective for somebody like you who, when you first got docetaxel, even though you had such a rough time with it, it held you for so long.
Yeah, I was just thinking about that. We never discussed this, so I'm going to bring that up.
Yeah, I mean, if you're open to it, then I would definitely discuss cabazitaxel, Jeftana.
Yeah, exactly. All right. I really appreciate you guys. Thank you.
Okay, I'll just throw in one last comment for you, Larry, which was when I met with my medical oncologist just last week, and we were discussing the way forward for me. He said, I think it's more appropriate for you to go on Zytiga than chemotherapy because you have low volume disease, and yours is probably even lower. So I think that the advantage to using chemotherapy is for high volume metastatic disease, not low volume. You're better off, in other words, you're better off with Zytiga, apalutamide, enzalutamide.
Yeah, well, I guess I'll have this whole discussion. We talk comfortably together. Thank you.
All right, sure.
Hey, Larry, this is Dennis. I'm back, and I found my paperwork here. And like I said, I'm with Humana Part D plan. And my first monthly payment for the Zytiga alone was came to, after the various discounts and everything else, $2,463. and that put me into what they call a stage 4 situation. And then since then, I have been paying $582 roughly a month.
Yeah.
That's
Yeah,
what
I was thinking about that, like 5% of the cost they were saying. So that makes sense to me. Thank
Okay.
you.
Yep.
Okay, Paul, you told us you wanted some airtime. Paul Frieda?
Sorry, my microphone was off.
Sure.
Yeah, I got just a couple issues that are not prostate related. I had a spot on my pancreas, and last year I had an endoscopic ultrasound, and he couldn't find anything to biopsy. They told me to wait a year and have an MRI, and I had a CT scan about a year later, and it showed nothing, whereas earlier CT scans had shown 6 millimeter and 1.1 millimeter cysts on the pancreas. But then they had the MRI, and it showed a 9 millimeter cyst there. So I'm going to see the pancreatic doctor next week, early next week, and hopefully it's nothing, but we'll find out. Then the other thing is I had a routine blood test and that my PCP wanted, and my bun and creatine are high by like 20%. They've always been marginally close, but apparently they've gone a little higher. So I may have some kind of kidney issue. I don't know. So I've got some things going on.
Paul, did they give you any differential diagnosis for what was it, 0.9 millimeter?
No, 9 millimeter. The MRI showed a 9 millimeter cyst, but the strange thing is that the CT scan a couple months later showed absolutely nothing. However, when I had the CT scan, there was something irregular about the procedure. The nurse had some kind of problem, and I kind of felt uncomfortable about the way she solved it. She seemed to do it in a quick rush, and I have no idea how that might have affected the outcome and the results, but there was that. So I don't know. But the CT scan should have showed something, because earlier CT scans showed spots on the pancreas as far as back as 4 years ago, but they were stable. You know, the next CT scan would show it the same size, and it wasn't until last year when it doubled and almost doubled in size that my medical oncologist immediately got me in with the pancreatic doctor. So anyway, I'm a little nervous, but hopefully it won't be anything. We'll see.
And what would they do for a pancreatic cyst?
Well, I think I'm trying to decide whether I should insist, but the right thing would do another endoscopy and endoscopic ultrasound and see if he can get a biopsy, or if it goes, when he did it last year, he said he couldn't find anything, and to take a biopsy, so maybe the same thing will happen this year. But at the same time, he may just say, wait a year and do another MRI. And I don't want to wait a year, because if you make a mistake with pancreatic problem, you can be gone in 4 months. So we'll see what he has to say on Tuesday.
Okay.
Yeah.
Well, we wish you well with that.
Yeah. Thank you.
Any questions for Paul? Okay, so you had an increase in BUN and an increase in creatinine, I think you said.
Yeah.
So yeah, those are measures of kidney.
Kind of high, and this time it's over, and so I'm wondering if I'm going to have to change my diet, or I have some other kind of kidney problem. But I have to see my PCP about that, and we'll see what's going on there. So.
Okay.
But otherwise, I'm feeling fine. I'm playing tennis almost every other day, and I feel pretty strong. And my next scheduled blood test is in about 2 weeks, and find out if my, I'm on Lupron holiday, so we'll see. My testosterone should be continuing to rise, and hopefully, fingers crossed, the PSA will still be undetectable.
How's your weight doing, Paul?
Holding it at about 260, and it's not too bad, but I haven't been able to continue go down. But I really should try to get down to 225 if I could, something like that. But I don't, I did a 3-day fast about 3-4 weeks ago, and I didn't have any problem with it, and I lost like 6 pounds, 5-6 pounds, and I thought, well, this is great. I'll do this once a week, but I haven't been able to do it again. So.
Did that 6 pounds stay off, or did it come back?
No, it's pretty much stayed off. Yeah. So I'm good at eating small meals, but I fall off the wagon every so often, and have some Doritos and or some ice cream or something like that. But so it's a struggle. I'm sure everybody who's tried to lose weight knows what that's like. But I think my long-term health, the more weight I lose, the better I'll be. So better off I'll be. So.
Paul, this is Jake. Have you talked to your doctor about the possibility of taking metformin?
No, I haven't. Is that to help you lose weight or something?
Yeah, well, metformin is supposed to be for diabetes. It's usually the go-to drug when you're first diagnosed with diabetes. But if you're pre-diabetic or anywhere close to it, you might be able to convince your doctor to prescribe it for you. And it does have a benefit or a side benefit of weight loss.
Okay.
And it's a relatively innocuous pill. As far as the medicines that we all take goes, metformin is probably one of the least innocuous ones there is. It's worth just mentioning it. They probably, unless you're close to being diabetic, they probably will say no. But I mean, it won't hurt to ask.
Well, because I was up almost to 285 at one point, and
Right.
my doctor, it's quite obese, and he was suspecting that I was getting close to being diabetic, and he ran some tests, and it said that I'm still okay. But I'll mention that to him, see what he thinks.
Yeah, if your glucose is less than 120, or if it's over 120, they consider you diabetic. But if it's less than that, like between 100 and 120, it's called pre-diabetic. And I don't know what your glucose is, but if it's anywhere between 100 and 120, then you might be able to very well get your doctor to give you metformin.
I can get it here. 1 second. Let me just take a second.
Okay.
I do want to add, because this came up in some correspondence with Ken Anderson this week, that most men who are LHRH therapy will show an increase in their blood sugar to that pre-diabetic level. So it's not unusual. And while it may be a good argument to get metformin, my doctor's always said, you're not diabetic, this is just a result of the hormone therapy. Now, since then, because that was 10 years ago or so, we know that, or I don't want to say we know, but there are better and better arguments that adding metformin to your regimen is probably helpful. Yep. And it rarely hurts. And if it does hurt, then maybe you're taking, as Jake will attest, a little too much and you cut it back. Right. Having said that, don't be alarmed if you're over 100. Always said to me that they wouldn't intervene and do anything until my level was about 150. That's what my doc said.
150?
Yeah.
Yeah, I'm 102. I just checked. I'm 102.
Right.
Yeah, that's low end. That's, your doctor probably will not consider that an issue. But again, you can ask. What Rick's talking about, there's a protocol called SAM, SAM, statin, aspirin, and metformin that some doctors recommend. I don't remember who it was exactly that recommended it, but You know, all of them are relatively innocuous, and they seem to have some benefit. And metformin is also supposed to have some benefit on prostate cancer itself.
Really?
Yeah, I don't know if that's proven or not. Len probably can tell me that.
Yeah, for patients who are diabetic, trials show that metformin does improve prognosis. However, if you're not diabetic, uh, I think it either showed that there was no benefit, or it hasn't even been tested in patients who are not diabetic. I can't recall which, but in any case, there's only proof that metformin is helpful in patients for prostate cancer now, patients who are diabetic and prostate cancer.
You know, I can add a little bit to that, Len, and it's Ken Anderson.
Sure, go ahead.
I started taking metformin about a year ago, and it was because Paul Korn at MD Anderson said there was in fact benefit for guys like me without I'm not pre-diabetic or anything. He said it just lowers, I guess, sugar. I don't know. But he put me on it, and I've been taking, 1 pill a day ever since. And he put an order in, and my doctor local, my MD, filled it, so it was not a problem at all.
Okay, if you could, Ken, ask Paul for a reference showing how metformin helps non-diabetic prostate cancer. I'd be interested in reading that.
I'm going to see him on the 16th, and I'll ask. But I do remember him saying that he didn't have proof, but he just thought it did.
Oh, okay.
I mean, we have, and we send out and have sent out various papers over the time that show metformin, the value of metformin. And I they may even be on the website. I don't know. If not, I should probably put them on the website when I have a minute. But the studies get questioned. But I mean, there's one paper, I seem to recall it was Dr. Steve, God rest his soul, who found it, that had about 5 or 6 studies listed. I'll look for it in a second and see if I can put it in the chat window.
Okay, thanks, Rick.
Just for anybody's for reference, anybody who's taking metformin or planning on taking it, make sure you take it with a meal, because otherwise you'll be in the John quite a bit. I'm speaking from personal experience.
Right, and also, why don't you share how you dealt with being in the John so much, and how you rectified that?
Right. This is Rick's doing. I started out with 500 milligrams extended release, because it's supposedly a little bit easier on your body rather than giving you a solid dose right all at once. It gives it to you over the period of the day. Then I increased it to 1,000 milligrams, and that's when I started having problems. Even though I took it with a meal, I was having diarrhea like you just wouldn't believe. So Rick made the very good suggestion and says, well, dummy, why don't you go back down to 500 and try that?
I didn't say dummy. Hold on.
I know he didn't say that.
He was thinking it, but he didn't say it.
Right, exactly. But no, I took his advice, and it has made a big difference. As far as the diarrhea goes. I still have my moments, but I think that's unrelated to the metformin. But the big thing, the key lesson here is take it with a meal.
All right. Thank you, Jack.
Thank you.
No problem.
Oh,
have I earned my key for the day, Rick?
Oh, yeah. Oh, yeah. Other than trying to slander me, that was just fine.
Well, everybody knows you would never use a term like that.
No.
All right, Jake, check's in the mail for you. You earned your key.
Thank you. I need it.
Okay, we've got 2 minutes. I think I'm the only one left, so I can do this in 2 minutes.
We also didn't check in with Sylvester, Len. I'm sorry to interrupt you, but we didn't check in with Sylvester.
No, thank you. I was on mute. thank you very much, but I don't have anything to add.
Yeah, I deliberately didn't ask Sylvester. Sylvester, you should just proactively let us know anytime you want to take some airtime so we'll know.
Very good. I'll do that. Thank you.
Okay. All right, so quickly from me, anybody who's been on the call the last couple of weeks knows that I had the PYL scan. It showed bone lesions. One positive from the biopsy. Perhaps there are others that are positive, but we're not going to be biopsying everything. So, as I mentioned in the discussion with Larry, he said your metastatic volume is low, so we would not recommend chemotherapy, rather Zytiga, which he's going to put me on. I haven't started it yet. I've been on the Lupron. And even before I started Lupron, of course, as everybody knows, you take bicalutamide first. I was on that for 10 days alone, and the PSA went down from 2.4 to 1.4, which was good news for me because I'm still hormone sensitive, apparently. So we're going to add Zytiga momentarily. I think they're notifying my pharmacy now, and I'll be picking that up in the next few days. And so my oncologist recommended I consult with some top-notch radiation oncologist in New York City. And he gave me a couple of names. Zalewski, everybody's probably heard of him at MSK, and a Dr. Richard Stock at Mount Sinai. So I have an appointment so far with Stock, and I might get one with Zalewski also. And that's it for me. And it's 8 o'clock.
So I have a couple of little things. First of all, I'd like to give you a very quick update on Professor Bill. I spoke with him this morning, and as I mentioned during the call, he just got done cleaning the downstairs of the house. And I said, Bill, this is amazing. I said, I can't believe you. Well, I've been getting up at 5 o'clock every day, and I start 5 a.m. and I start writing, and and I said, well, it's great. He said, yeah. He said, since I went into hospice, I've been feeling way, way better. And I said, well, I'm just delighted for you. I'm really thrilled. Unfortunately, his wife's mother just went into hospice in Florida. And as he pointed out, they don't accept people into hospice in Florida unless they think they have less than 4 weeks to survive. And his wife's sister, who's been sick for a very long time, has total renal failure. So Deb's really going through it, and she's making plans to go down to Florida. Of course, my immediate concern is who's going to be with Bill, and there are a couple of options, probably his brother. There are other options, and I told him, if he can't find anybody, I'd come out and help him. But he seems to think that it will get resolved, and hospice has said they feel that they can work with Bill. And the other thing is that the hospice has an in-house facility, which Bill says is like a 5-star hotel, and it's available not just for patients, but as a respite for caregivers. And he says he wouldn't mind going to try that for 5 days. I said, Bill, I know. I said, you think you're going to be in a luxury hotel for 5 days? Yes, he says. So, but my concern with him doing that is, who's going to go visit him? He's going to be on his own. And psychologically, I don't think it can be that good, but I ain't Bill. So the bottom line report is that he feels really well and he doesn't feel like he's deteriorated any. And he's in fact improved since I saw him, which is about 3 weeks ago now in Buffalo. So I'm really, really happy about that. I felt quite encouraged him. Bill said he's going to be around for a few months yet. He says, we know it's what the inevitable is, but I'm going to be here for a few months yet. And I said, I hope so, Bill. God bless you. So that's one thing for you who are on the call and for everybody who listens into the call who I know is anxious to receive news on how Bill has been doing. And we can only hope that the brain radiation for Tebow will be just as effective. I am back. I'll be back stateside on Friday, and we will have a meeting on Monday night. I know it's Labor Day, but we will have a meeting on Monday night, and whoever would like to join is, as always, very welcome to join. So that'll be next Monday. And I like this program where Len takes the lead, actually, because it makes it a lot easier for me to take notes on people and look for stuff. And that's a perfect segue into the fact that I did post something in the chat window on Metformin just now. I hope it's the right article. I didn't actually check because it was all so quick.
I took a quick look at it, Rick. It was a 2013 publication talking about future directions of prostate cancer treatment. So I don't know if I want to read a 6-year-old.
It wasn't the right one. Yeah, you're right. It wasn't the right one. All right. Well, what I'll do is I'll try and I'll have to take some time to look for it then, and I'll be sure to post it next time, or I'll put it in. I'll put a reminder when I write next week's circular to find the right one and to put it in the reminder. I'm putting something in my calendar right now. So that's it. That's all I wanted to say. We only ran 6 minutes late. Jake, don't close the room, please, but stop the recording whenever you want. And we'll all say goodnight. I'll let Len say goodnight. But Len and Jake, hold on just a minute after everybody leaves, please.
Okay. Well, thanks again, everybody.
Thanks, everybody.
Good night, all.
Good night, all.
Good night.
No.